Okay, so what we're going to do is just go through what you've gone through already. Okay, so obviously from the radiology challenge, it's really kind of orientating yourselves with regards to the coronary anatomy, but also the cardiac chambers, because traditionally we kind of close our eyes to looking at the heart. And obviously from the cardiology point of view, what you're going to have to get used to is looking at images in a totally different way. So in other words, in the orthogonal planes and in the multiplanary format. Remember that obviously the anatomy is the anatomy, and this is a great way of consolidating the 3D anatomy in your heads, whether you're from a radiology point of view or cardiology background. So in fact, we often kind of teach the anatomy of the heart using CT because it's such a powerful tool. Okay, so what we're going to do is just talk about the orientation of the heart and the nomenclature. Obviously, for cardiologists, you'll be relatively familiar with that. Concept of windowing, you've already touched on already, and then we're going to talk about anatomy of non-coronary and then coronary structures. Okay, so the first thing to remember is when the heart lies in the chest, it actually lies in two planes of obliquity. So for those of you who come from an MR background, you know to get the left ventricular short axis, so in other words, to correct for the double obliquity of the heart, you have to go through the two steps of first correcting for the mitral valve annulus to the apex to get the vertical long axis view. So you correct for one plane of obliquity, and then if you have a horizontal long axis, you correct for the second plane of obliquity. So the principle is you correct for the fact that the heart lies to the left and also craniocaudally. Okay, so remember from the axial image, as Taryn's already said, you're looking effectively from the feet above. So what you have to remember is anterior will kind of be forward, posterior will be back, and right and left as per chest x-ray. Okay, so Hansfield unit. You've already heard that the Hansfield unit is just a way of quantifying the CT pixel value. 0 is water, plus 1,000 tends to be bone, and minus 1,000 tends to be air. Obviously, there's a range of numbers between that. Why it's important is, although obviously the gold standard for tissue characterization remains MRI, CT can still give you very important information as to tissue characteristics, albeit not to the same resolution. So what you can do confidently, for example, on CT is say when something's got fat in it. So that can be helpful, for example, if you're looking fatty metaplasia, maybe post-infarction. Even there's been descriptions of looking for ARVC, for example, on CT imaging. So CT is a very robust way of identifying fat, and you're relying on this negative Hansfield unit. In the same way that it's very good at looking at fat, it's also very good at looking at bone. So you think about what do we do as kind of for trauma, we always do a CT because CT is so sensitive for identifying calcification. So in other words, you can use that to your advantage. So for example, when you're looking at pericardial disease, you often do a CT and an MRI. So the point is all of these techniques, what we're trying to do is teach you kind of a multimodality approach and what the strengths of each technique are and how they can work in synergy one another to help you solve clinical problems. Because that's effectively what they are. They're tools to help you solve a clinical problem. So we've already talked about windowing, which is basically just optimizing the brightness and the contrast. Although, as you've seen, there are set windows, a window length, window width based on lung, soft tissue, whatever you're looking at. What you need to get used to is even before you start looking at the image is optimizing the image based on the contrast. So when you look at an image, you'll automatically say, oh, that looks a bit too bright, so you should change it. And you'll learn how to do that during the course, so you'll kind of get an idea of what suits you and what is a diagnostic appearance of the image. Okay, so again, Taryn's already touched on this, so looking at the cardiac soft tissue. So traditionally, again, you can learn these numbers, but most of the scanners, most of the workstations will have defaults. You can obviously optimize these, but they're useful at least to start you in the right ballpark. So for example, if you're going to look at soft tissue, you go to a soft tissue window, and then you can manually adjust it. Okay, so again, looking at the lungs, remember CT data has got a spread of grayscale that's much, much more than you can see visually. So the idea is you change the grayscale based on the structures that you're looking for. And obviously you'll adjust things for the window width and window length, for example, to look at the lungs. Okay, so let's move on to the anatomy. So one of the ways that we're going to try to look at the anatomy is from the axial plane. Again, kind of most cardiologists won't be used to looking at the anatomy this way, but it's a good way to kind of try to at least start interpreting the image. What's very useful is you should always use all the planes whenever you're trying to resolve what a structure is, especially if you are not entirely sure. Okay, so for example here on the coronal image, you know you're at the aortic arch. So just to orientate yourself, you can see the branches of the aorta. So does everybody know what the first branch of the aorta, once you've gone past the coronary, is? Obviously none of the cardiologists know this. Again, surprise me. Maybe not. Okay, so it's the innominate, okay, or the brachiocephalic, which then obviously splits into the common carotid and the left subclavian. And so on the left, then you've got the common carotid on the left, and then the left subclavian. And those are your traditional arch vessels. Obviously, there's a variety of anatomy, and you can kind of get common origins, you can get independent origins, especially of things like the vertebral. But the key is, obviously, you're looking at the arch, and what you should see usually on the right side of the arch is the structure called the SVC. Now, one of the review areas that I always encourage people to look for is just adjacent to the aortic arch in this area here. There should not be a vessel there. If you do see a vessel there, it's going to be one of potentially three things, usually two things. Sometimes it can be a pulmonary vein that's just kind of a bit of an odd position, but that's unlikely. So the two commonest things are going to be persistent or a left-sided SVC, or no, azygos is going to be on this side. So it's going to be anomalous venous drainage of the left upper lobe. Okay, so that's the classic. And the way to distinguish those two on imaging is obviously you can follow it up and down because you've got a volume of data, and you can see if there's an absent pulmonary vein and you see the pulmonary vein draining into the brachiocephalic and the brachiocephalic coming across, then it's anomalous venous drainage. If you see the brachiocephalic, which normally two brachiocephalics form the SVC, right? If you've got a left and a right, usually the brachiocephalics stay separately, so you'll see them go down. And obviously the other clue, as you know from echo, is you look for a dilated coronary sinus, because if you've got a left-sided SVC, drains via the coronary sinus. So the golden rules that I always teach are look at the review areas, and I'll show you some of the review areas. The other thing is when you look at the axial image, the most anterior valve should always be which valve? On an axial image. It's always going to be the pulmonary valve, okay? If the pulmonary valve and the aortic valve have got an altered relationship, then you're starting to think about, is this some sort of transposition? In the same way that your most posterior cardiac structure should always be your left atrium, yeah? Think about it. The left atrium abuts the esophagus. So you know, for those of you who kind of see EP procedures, esophageal injury is the kind of one worry or one of the worries of our EP colleagues because it's slap bang against it. So the other golden rule is to remember the structures that drain into the right atrium, which are obviously going to be SVC, IVC, and coronary sinus. Okay? So you just have to learn, unfortunately, a few of the kind of basic anatomy bits. But it's quite useful to kind of learn these golden rules because it will get you out of trouble if you're not quite sure what's going on. Okay, so we've already touched on where the SVC is. And remember, the SVC is formed by the brachiocephalics. So one of the things that you should see is the brachiocephalics going across. Another reason why it's important to pick out a left-sided SVC is obviously if you're doing it as part of a pulmonary vein study to make sure there's no pulmonary vein stenosis before somebody has an EP or even a pacemaker, you don't really want to miss the left-sided SVC because otherwise your colleagues will get really annoyed with you. Okay, so obviously tucked in between there, you've got the trachea, and for those of you from radiology background, you know that there's loads of vascular anomalies, especially in the pediatric population where you can get these various slings that kind of potentially cause tracheal compression. But obviously that's another talk. So when we're looking at the aorta, remember the aorta in the same way as the heart lies in a plane, a double obliquity plane. So we often get this candy cane or hockey stick view, for example, on MRI. And the way that you plan it on MRI is obviously you can either do a three-point plan, but if you don't have that, you can cut through the ascending and the descending aorta, and usually that cuts through the aortic arch. Obviously, if it's very unfolded, if it's very tortuous, then it's going to be difficult to get it in a plane. But the advantage of CT is you've got the volume. So often our surgeons, before they do any aortic valve surgery, even if we've done all the measurements and everything on MRI, they still want the CT because they can sit there, they can rotate it around, get the anatomy straight in their heads, they can look at the relationships if they've had previous bypass surgery of the lemur graft, the stenotomy in relation to the right heart. So all of these are kind of bread and butter indications for CT. And if you're doing cardiac CT, you'll often be asked to do all of this stuff. So it's useful to kind of familiarize yourself with the anatomy. So again, you can see the three vessels, and obviously the three vessels will vary. So where do the lemur grafts or where do the lemur vessels come off? Or where does it come off? So left subclavian, yeah. So the other thing to do is if you're reporting a graft study, obviously make sure that the left subclavian artery is patent and there isn't a critical stenosis there. I've seen a couple of cases like that. Okay, so back to the axial anatomy. So here we're quite high up. We've already talked about the SVC, which is kind of just forming there. That's your brachycephalic vein. So one of the things that you'll learn in doing cardiac CT is we preferentially always try to inject contrast from the right side rather than on the left. And the reason for that is you get streak artifact if contrast is very dense. So this will basically just be right by your subclavian artery. So if you're looking at a graft case, you know the origin of the lemur is going to be off the subclavian, so you don't really want to be obscuring that. So ideally, you always try to inject from the right. Obviously, if you can't get access, then you have to go from the left, but you just need to be aware of that potential problem. So brachycephalic comes around, joins the other brachycephalic, forms the SVC, and then you've got your three vessels. Obviously, there's the trachea, there's the esophagus sitting behind it, and you can often sometimes see a little bit of air in that. Okay, so we've gone through all that. Okay, so as we're going up for some reason, sorry, these are Taryn slides. So as you head north, obviously the brachycephalic splits into the right common carotid and the right subclavian. Obviously the subclavian stay the same, and what you'll see here is the brachycephalic staying as separate. Okay, higher up, you'll often see the thyroid, and the thyroid traditionally has high attenuation because it's got loads of iodine in it. So even on an unenhanced study, it will look bright, and it's just the iodine which is what's in contrast. And obviously you'll see the common carotid eventually splitting into the internally external. The vertebrals will come off the subclavian, so you'll sometimes see the vertebral arteries and obviously the subclavian arteries. And similarly, you'll see the jugular veins. Okay, so moving down here, so obviously we're now going into the descending aorta, and you've already heard from Taryn the way we define the aortic root is from the insertion points, or as we call it, the annulus, although I'm sure all of you are aware it's not a true annulus, it's the actual insertion points of the aortic valve. The sinus of Valsalva, which is that bulgy bit, and then as it returns to a more normal caliber, that's the sinotubular junction. So that's what I would call the root. Everything else is the ascending aorta up until the origin of the brachycephalic. So that forms the ascending aorta. Then if you look at the surgical definition of the arch is defined as from the brachycephalic to the ductus arteriosum. So it's often beyond the left subclavian, but most people would take the arch as going from the beginning of the arch vessels to the end of the arch vessels, and obviously all the rest is descending. So that's useful when you're talking about dissections. You've got to be familiar with the anatomy because obviously type A management is totally different from type B. Okay. So moving down to the level of the carina. Now, one of the things that we always do is when you're planning a cardiac CT is you have to plan your field of view. So one of the things that the radiographers always do is on a calcium score, you always start at the level of the carina. And that's usually above the origin of the left main stem, which tends to be lower down. Okay, and the reason why we plan it like that is that you can be confident that you're going to get the origin of the left main stem, because the last thing you want to do on cardiac CT is cut off the left main stem, or any of the vessels, in fact. So you always end up starting with a larger field of view. So the landmarks are always the carina, so you need to be familiar with that. And you can see here the carina, so it's a tracheal bifurcation splitting there, and to the lower part of the heart. Sometimes it's actually difficult to predict where the heart ends because it doesn't just end at the diaphragm, it can kind of loop down. So I always tell our radiographers when you're doing a calcium score, if you're not sure, just make your field of view a bit bigger, because what you don't want to do is cut off a bit of the heart and then you can't even do the calcium score. Obviously, once you've got the calcium score, what you can then do, as Taryn will show you in the course of the course, is refine your actual image acquisition when it comes to doing the CT coronary angiograms. And one of the ways that you can do it is because you can see the coronary vessels, you can plan a little bit above and a little bit below to allow for variation in inspiration, expiration, but at the same time keeping your field of view as narrow as possible. Remember, the smaller your field of view, the less radiation, the lower your dose. Okay? So you should always aim to try to scan on the smallest field of view. Okay, so here's the carina, so you can see the trachea is bifurcated. There's the ascending aorta. You can just about see the pulmonary valve there. And obviously there's your pulmonary trunk, and then that splits into left and right. Does anybody know what this structure is? Say again? So it's a pulmonary vein. So that's where you can sometimes get caught out if it kind of stays quite medial and you go up to the arch. But when you're looking for a left-sided SVC, when you're looking for anomalous venous drainage, just look at the level of the arch, because usually the pulmonary vein doesn't go up that high. Okay, so as we're moving down now, you can see the valve proper. Taryn talked to you about the conus, so you can see that the conus, or the infundibulum, is kind of more a fibrous tissue, so it's thinner before you get into the muscle itself. What you can also see often at this level is the right atrial appendage, which can be heavily trabeculated. I've seen thrombus in the right atrial appendage, so you shouldn't dismiss it outright. And similarly, you'll often get the left atrial appendage just here. Okay, moving down. Often what you'll see, because of the way the heart is angulated, is you often see the left main stem coming in first, or the left coronary arteries before the right, because the heart's tilted that way. So if you look here, you can see it's the left main stem. When you're looking at origin of the coronary arteries, it's much, much easier to look at it in the double obliquity of the aorta. So you line up with the aortic valve, and then it becomes much easier to identify the appropriate cusps, and then to identify the appropriate sinuses, and then to identify whether it's a normal coronary anatomy or not. It can be a bit tricky sometimes off the axial, but you'll get used to looking at it from the axial. So for those of you who do MR, it's quite helpful because it saves you having to load it into a workstation to look at it in 3D. Okay, so again, you can see left atrial appendage. Now we're getting the pulmonary veins. Remember, the pulmonary veins will always stay with the left atrium, so it's a way that we use, a way that we try to identify the left atrium whenever we're looking at congenital cases. Okay, moving down now, what you can see here is the origin of the right. You often see these diverticular, so these aren't necessarily pathological. In fact, they're normal variants. But it's good to kind of familiarize yourself with the normal variants, because sometimes you'll be asked by one of your colleagues, oh, I've seen this on echo, what do you think? And if you look at something, if you're not used to looking at these structures, you'll find it difficult to say whether it's normal or abnormal. So try to kind of develop a bank of what normal should look like, because it's extremely helpful. Okay, so moving down further. Here we've gone below, so we're just at the aortic valve. So you can see the aortic valve, although it looks like it's trileaflet here, obviously it is in this case, but it's not the way to say whether the aortic valve is trileaflet. You should always do the double oblique, because it can be quite difficult to interpret it. What you'll see on the double oblique is you use the same rules as you do on echo, which is to identify the non-coronary cusp. You use the interatrial septum. So the interatrial septum will always abut the non-coronary cusp, okay? So again, what you can see is here, you probably just about see a sinoatrial nodal branch, which is of not real any significance, but it's just good for you to see it. Sometimes you'll see a conus branch going anterior to the conus. Okay, so moving down even further. Now we start getting into the ventricles. You can see the moderator band, as Taryn said. There's the hallmarks of identifying the right ventricle over the left ventricle. The moderator band's a very good way of doing that. You can see here there's the crista. So the crista is that kind of muscular band that forms from the SVC and the IVC, and that can look quite prominent, especially when you reconstruct a four-chamber, but this is a kind of normal appearance. Here you can see the interatrial septum, and if you measure the Hansfield unit, or the pixel intensity of this, you'll see that it's fat. So CT is a very good way of identifying, for example, if you've got interatrial fat hypertrophy. And as you know, sometimes you can get confused as to whether there's a mass there or not. If you don't have easy access to MR, you can nail it on CT quite readily, because you'll be confident that it's fat. Okay, so moving here. So again, you can see the fossa ovalis here, so often it looks quite thin. Sometimes identifying ASDs can be quite tricky on CT, simply because it can be difficult because you don't see the jet that you traditionally see if you're doing an MRI or an echo. So it can be quite difficult, and the septum itself can be extremely thin, so it can be difficult. But you typically get the sparing of fat in the fossa ovalis, so this is kind of a normal appearance. Moving down further, you can see the crista again, and here we're getting the inferior pulmonary veins. And then as we start coming off the heart, you can actually see the coronary sinus. And you can see the coronary sinus IVC. So you know the three structures draining into the RA. We've already seen the SVC, IVC, coronary sinus. And you can see that quite nicely. One of the things that you should be alert to, at least, and one of the things that you should do when you're doing coronary anatomy, is get used to reconstructing all the standard planes. And there's two advantages to that. One is obviously it gives you a second chance to see something that you may have missed just by scrolling and looking at the coronaries. But more importantly, as those of you who are from an echo background, you're used to looking at the three-chamber, you're used to looking at the four-chamber, you're identify the relationships as to whether they're normal or abnormal. So it's a really useful skill to do because it forces you to look at the image as if you were looking at an echo. And similarly, if you're from an MR background, it will get the 3D anatomy sorted in your head and also force you to look at it in the same way. So, for example, if you do a 2-chamber, you'll see the coronary sinus right up against the left atrium. You'll see if there's deroofing of the coronary sinus, which is obviously rare, but you don't want to miss the rarities. That's the point. Okay, so as you head further south, then you start getting into IVC, joining into the hepatic veins. You might see the hepatic veins. Obviously, in this case, there's a coronary vein here. So some people use CT, for example, to identify coronary venous anatomy. What you have to be aware of is when you're doing a cardiac CT, because of the way you time the contrast, you may not get adequate opacification of the coronary venous system. So if that's a question, then you have to modify the way you give the contrast. Okay, so looking at the pericardium, Taryn's favourite question is how many layers of the pericardium do you see here? Is it 1, is it 2, or is it not either of those? Or where is the pericardium even? Okay, so to put you out of your misery, remember pericardium is a potential space. The pericardial fluid forms between the 2 layers of the pericardium. So if there is no fluid, the pericardial layers should be adherent pretty much. So what you're seeing here is the 2 layers of the pericardium. Okay? In between the pericardium and the myocardium is epicardial fat. So when people talk about epicardial fat, that's what they mean. And the coronary vessels will sit in the epicardial fat. Okay? So here, if you look at the left ventricular short axis view, there's the LAD. You can see it's comfortably sitting in loads of fat. One of the things that you'll sometimes see is myocardial bridging or an intramyocardial course where the LAD is actually running in the muscle. So that can be quite useful. And this is a good view to see that. The other thing that you can identify is obviously pericardial fat or mediastinal fat. And in this case, what you can see here is there's thinning. Anybody know what that wall is? Obviously, use your 17-segment model, which we'll talk about for radiologists. So posterior or infralateral wall. And do you see how it's got low attenuation in it? This is fatty metaplasia. So fatty metaplasia, for all intents and purposes, is a hallmark of infarction. So the chances are they've had an infarction of the infralateral wall. And you're at the level of the papillary muscles. You can see it here. So that's going to be mid-ventricular level. Okay, but we'll talk about the 17-segment model in a sec. Okay, so again, parietal and visceral layers, 2 layers. So MRI can be very helpful because sometimes even though CT has got better spatial resolution, remember the spatial resolution of CT is about 0.5 of a millimetre, whereas on MR, even if you do a kind of 3D whole heart sequence, you very rarely get less than about a millimetre. But where MR is advantageous over CT is the tissue characterization. So sometimes if you've got what looks to be fluid on CT, you're not quite sure because it's difficult to measure the Hansfield unit, then MRI can be helpful if you're trying to distinguish whether it's pericardial thickening or if it's maybe some fluid. So always with pericardial disease, I always say you should do a CT and you should do an MR and use the information together, obviously together with echo. Okay, so here's the MR. You can see kind of there's fluid signal here in between the 2 layers. You know that this must be fat because you can see the epicardial vessels in it. Sometimes, for those of you not familiar with MRI, we use this sequence called an SSFP, a steady state free precession, which isn't really T1 or isn't really T2 weighted, and it's a balance between T2 and T1, so you can't use it to reliably distinguish different types of tissue. So fat and fluid can look equally bright, so it can be a bit confusing. Okay, so going on to the chamber anatomy now. Okay, so remember your standard orthogonal planes. So axial image, which is the transverse image, coronal from the Latin crown, and sagittal from the Latin sagittas, meaning arrow. So easy to kind of orientate yourself. And we'll always look at these 3 planes. So here's Taryn's kind of showing them how you split up. So here's the axial image. When we cut through the mitral valve annulus and the LV apex, we're correcting for the first plane of obliquity, which gives us the vertical long axis or the long axis 2-chamber. Remember, this is not a proper 2-chamber because in a proper 2-chamber on echo or an MRI, you should really be cutting through the anterior and the inferior wall, okay? Because you've not planned this off the LVSA, you can't guarantee you're cutting through the anterior and the inferior wall. And in fact, when you actually look at a subsequent 2-chamber, you'll often see that this is sometimes cutting through the infraseptum even, or close to the insertion point. So it's well worth, when you're kind of doing MRI, for example, not being lazy and settling for the vertical long axis, but actually to plan a proper 2-chamber. So once you've corrected for this plane of obliquity, we then correct for the second plane of obliquity, which again, we go through the mitral valve annulus and the LV apex. So we do a second line going through that. And then that basically gives us what's called the horizontal long axis. So effectively, this is the vertical long axis. So there's your vertical image. And then cut through there, you get a horizontal long axis. So effectively, what we've done is we've corrected for the two planes of obliquity. So in other words, if you then line up here and line up here, you will get a true left ventricular short axis. So one of the principles that we always try, for those of you from MRI background, you know you often need two orthogonal planes to help you plan your planes correctly. Okay, so now we talk about the 17-segment model. So for the radiologists who are not familiar with this, what we do is we get the left ventricular short axis view, and then we divide it up into thirds. So the ventricle is split into thirds. You've got the basal third, then you've got the mid-ventricular third, and then you've got the apical third, okay? And then basically where the RV inserts is called the RV insertion point. And effectively what we do is we split up the ventricle into different segments based on the insertion points. So here. So what we've done is at the basal level and the mid-ventricular level, because there's more tissue, we can actually further subdivide these segments. But basically what you've got is your anterior and inferior walls on all the various bits. Then you've got the lateral wall, and then you've got the septum, okay? And then because we're higher up and you've got more muscle, you can cut that in half. And then you've got the anteroseptum, you've got the inferoseptum, you've got the infralateral wall, which confusingly can be called the posterior wall. So a lot of your cardiology colleagues will say, show me the posterior wall, and that's what they mean. And also the anterolateral wall, okay? And one of the things that you'll do on MRI, on echo, and even on CT is when you're looking at these walls to assess viability, it's often helpful to cross-cut these to get a true long axis. So you get a two-chamber but cutting through like that. You get a four-chamber which cuts through the anterolateral and the infraseptum wall like that. And then you get a three-chamber which goes through the anteroseptum and the infralateral or posterior wall. So the three-chamber gives you the posterior wall, anteroseptum. Four-chamber gives you anterolateral, infraseptum. Two-chamber gives you the anterior and the inferior wall. And it's all to help you report based on the 17-segment model. So it's extremely helpful when you're trying to describe a position of something, for example, pericardial fluid, to revert back to the 17-segment model, because then everybody, regardless of the modality background, whether it's MR, nuclear medicine, echo, knows what you're talking about. Otherwise, you know, as a radiologist, we tend to describe things based on the axial images or on the orthogonal views, which aren't the traditional ways that we refer to the anatomy of the heart.
Sorry,
Yeah.
One thing. Do you mean the 17th segment is the apex?
Yeah, so you include the true apex, or the apical cap, which is that bit. So, as our colleague pointed out here, Taryn's got another slide for it, I should have known. Okay. Teach me not to read his slides. Okay, so there's the apex, and that's the true apex. So that forms the 17th segment. Obviously, it's a bit difficult to comment on the true 17th segment because it's so thin. And often the apex, you'll be surprised, is quite paper thin, and you'll kind of get used to seeing how thin it can be on CT. Okay, so this is just a schematic using the 17 segment model, and the reason why we try to always report in the 17 segment model, especially when we're talking about viability, is because they're traditionally divided up based on coronary territories. One thing that you have to remember is obviously, although we kind of always report this as the LAD, and this is the right, and this is the lateral coronary artery territory, the anatomy varies, and it can vary enormously, okay? Obviously, if you've got a CT, it's helpful because you can actually see the vessels that actually subtend that territory. But obviously, you sometimes end up, if you have to, for example, on MRI, when we report viability, we'll always report according to the 17-segment model, and you'll get some smart aleck going saying, oh, but it's an LAD territory infarct, and you said there's an infarct in the right coronary. Yeah, okay, well, that's life. It's because the anatomy varies. Okay, so going back, four-chamber long-axis view. So four chambers because you see four chambers. The important thing to remember is on echo, most people call this the lateral and the septal. You can actually refine it a bit better based on how we've planned it. So you know that this wall is actually probably the anterolateral wall, and this is probably the infraseptum. Here you see the AV grooves. So the AV grooves are the grooves separating the ventricles from the atria. You've got the anterior and you've got the posterior. Another golden rule. The vessel that is most posterior on an axial image will always be your circumflex artery. Okay? So the circumflex artery always runs in your posterior AV groove in the same way that the right coronary artery should run in the AV groove. And the reason why that's important is Sometimes you can get caught out thinking, oh, is that big OM1 actually a circumflex? And you just revert back to that rule and it becomes really easy, especially if you're dealing with an occluded vessel. Okay, so here we're cutting through now, so we're basically effectively got the left ventricular short axis and we're heading north. As we head north, you get the interatrial septum. You can see the coronary sinus here coming through. And the reason why, obviously, it's not as opacified as the right atrium is because, you know, you've got a valve there. Do you know what the valve separating the coronary sinus from the right atrium is? No, Eustachian's IVC, isn't it? So Thebesian valve, right? Okay. So often it can sometimes be a little bit closer into the coronary sinus than you'd expect, but you often don't get contrast opacification refluxing because of that reason. Okay, this is also something called a C view, which I'm sure I'll show you, but Taryn doesn't like me showing you because it confuses everyone. I thought I'd get that in now. Okay, so going back to the aorta. So if we look at the coronal view, start off, so when you're doing TAVI, for example, and you're doing measurements of the aortic valve, which I totally hate, but you always start on the coronal view. And the reason why is you can kind of see the insertion points quite nicely on the coronal view. And all you do is line up with the aortic valve insertion. So if you think about it, if you want to get the aortic valve on fast, you need to correct for the two planes of obliquity, okay, coronal and sagittal, to get an axial image, right? So you start off with the coronal image, you line up with the aortic insertion points or the hinge points, which you can see here and here. Okay, so that gives you basically a fake three-chamber. Remember, this is not a proper three-chamber simply because you've not planned it properly, i.e. you've not planned it off the LVSA. But it's quite a quick way of giving you roughly what a three-chamber should look like. And then that can be helpful because it gives you a rough ballpark figure for whether the left atrium is enlarged. So again, a lot of the measurements that we use in CT, in the same way as the measurements that we use in MRI, they're all derived from echo. So that's why it's helpful for you guys to use the same planes that you're used to seeing on a day-in, day-out basis if you're using echo, because the relationships are pretty much fixed in your head, and you'll say, oh, that left atrium looks big, and you don't even have to measure it, right? Okay. Okay, so again, emphasizing what we define as the root. So it's the insertion points. The bulgy bit is the sinus of Valsalva, and then the bit where it becomes a bit narrower is the sinotubular junction. In hypertension, often you can lose definition of the sinotubular junction, so you can kind of get almost like a drain pipe aorta. Obviously, when you're measuring the aortic valve, what you should do, or not so much the aortic valve, but the aorta, ideally what you should do is measure in a double oblique plane. So when you're using the software, you can use the software to kind of straighten the vessel out for you, which makes it much, much easier to do the measurements. The important thing to remember is if you look at the aortic annulus, and you'll see throughout the duration of the course, that the annulus is not round, okay, it's an ellipse. So traditionally, when you measure on echo, you're measuring the sagittal view, but you'll actually see that the coronal view tends to give you a bigger dimension. So, for example, when we report on MRI or when we report on CT, you often report the bigger dimension. So you can have a big discrepancy between the echo measurement of the root and the CT or MR measurement, and the reason for that is because it's an ellipse. Obviously, all the outcome data is based on echo, so you could say, well, does it matter? It can matter because if you've got a very big elliptical measurement, so coronal measurement, then it's going to be more robust to follow that up using a different modality to echo because you just can't get that plane. Okay, so again, emphasizing that. Okay, moving on to coronary arteries, finally. Okay, so we've already said when you've done a double oblique view, you should get the pulmonary valve as the most anterior valve, and there's your right coronary. Now, normally, you get the interatrial septum here, yeah? So interatrial septum, you know from echo, for those of you who do echo, will always abut the non-coronary cusp, okay, or the non-coronary sinus. So in this case, we know that the anterior chest wall is here. The most anterior valve is basically, sinus is going to be the right coronary sinus, and surprise, surprise, it gives rise to the right coronary artery. And similarly, the one bit more posteriorly gives rise to the left. The pulmonary valve is a mirror image of that, okay? So you've got the anterior, and then you've kind of got the left and right, so it looks as a mirror image. So it's useful to think about the relationship of this when you're looking at coronary artery anomalies, and there's a whole talk about it, and during the course you'll see some examples. But what you should remember is the right should give rise to the right, and the left should give rise to the left, and nothing comes off the non. This is the bit that's important, which is the bit that runs between the pulmonary artery and the aortic valve, because that's where the arteries can get compressed, and that's one of the things that you should always look for when you're dealing with coronary anomalies. Okay, so Taryn's already said, think about the heart in two rings. You've got the AV groove, anteriorly and posteriorly. Remember, in the anterior AV groove, the right coronary artery runs. In the posterior AV groove, the circumflex runs. Okay, and usually they join up in the middle, and then they give rise to the PDA, which kind of runs in the interventricular groove, which is the other part of the circle of the heart. So in the anterior interventricular groove, you've got the LAD, and in the inferior interventricular groove, you've got the PDA. Usually, PDA arises in what we call the crux, which is at that joint. But the PDA can actually arise at different points, but traditionally, that's where you'll see it. Similarly, you know, from those of you who do angiography, you can get LADs that go all the way around, and so-called wraparound LAD, which actually surprise a bit of this. And what you'll see in CT is often, if one vessel is very big, the other complementary vessel tends to be a bit smaller. So you can kind of start understanding why the anatomy is as it is. Okay, so looking now on these images. So AV groove, right coronary, posterior AV groove, the easy peasy, that's the circumflex. Interventricular groove here is the LAD running at the LV apex, okay? As we head north, up pretty much in line with the AV groove, you can see here's the right coronary artery. And you can see it kind of coming off. In this case, it's giving off a conus branch. Yeah? Conus branch can arise separately, or it can arise from the right coronary. Okay, so as you head south now, you get into the interventricular groove, and again, you can see the LAD runs here and the PDA runs there. And remember, here you can see the LAD nicely cushioned around with epicardial fat. Sometimes you'll see it's kind of sitting right in the muscle. And this is a really good view if you want to understand bridging. And, you know, for those of you who do angiography, bridging, people say about 3%. It's probably about 30% on CT. We see it all the time. Obviously, the significance is a bit dubious, but anyway, that's another story. Okay, looking at the right coronary artery, although traditionally when we report cardiac CT, we tend not to comment on the SA nodal branch or the conus branch or the anterior RV branch or the acute marginal branch, which are all branches of the RV. We limit ourselves to the right coronary artery and the PDA and then something called the posterolateral branch. This is where the right coronary artery is dominant. So for those of you not familiar with this concept of dominance, it basically just tells you pretty much where the PDA is coming off. So if you've got a right dominant system, the PDA should come off the right. If you've got a left dominant system, the PDA should come off the left. And similarly, the vessel tends to be bigger, the one that gives off the PDA. So you get right dominance, you'd expect the right to be big and the circumflex to be small, and vice versa. There's also a codominance, where the PDA comes off the right, but the posterolateral branch comes off the circumflex. And often you'll see two vessels that are about the same sort of size. Okay, so the branches that we comment on the right are the PDA and the posterolateral branch. The way we divide up the right when we're reporting the right is think about the C shape, okay? So you've got the bit before it goes down towards the base of the heart, which is the proximal. Then you've got all of that to the mid, and then all of that is the distal, okay? So we divide it up in 3 bits based on the C shape: proximal, mid, distal, okay? Okay, so LAD. For those of you who do angiography, you know that we divide up the LAD in proximal mid based on the septal or the diagonal branches. So usually you'll get a left main stem, which is the kind of conduit that then divides up into the circumflex and the LAD. And you know it will be easy for you to identify it if you follow the rules where the circumflex is always the most posterior, the LAD must be running in the anterior AV groove. Okay, so the circumflex gives off certain branches. They're obtuse marginal branches, just called 1, 2, 3, whatever. The LAD, diagonals, 1, 2, 3, whatever. Traditionally, we'll maybe see the first. We don't really see the second very well. And then you very rarely see septal branches unless you've got a very big LAD, and usually in young people. But it's not uncommon not to really see the septal branches very well. So when we report, we divide up the circumflex into 2 bits, proximal and distal. And it's divided up by the obtuse marginal. So usually OM1 splits it into the proximal and the distal. The LAD, we try to follow the angiography convention. So where you see the first diagonal splits the LAD from the proximal to the mid. Now, because we don't see D2 often, or even some of the diagonal vessels, the way that we report the LAD is a little bit different from coronary angiography in that what we do is once we've identified the proximal, to separate the mid from the distal, we basically use the arbitrary value of looking at the length of the vessel from the LV apex and splitting it about in half. Okay? So it's a little bit more arbitrary than on angiography where you'll define it based on the branches. So, right, look at the C, proximal, mid, distal. Circumflex, proximal, distal. I sometimes use this concept of the mid portion because I'm just trying to convey where it is because obviously if you say distal, most people think it's quite far away. And similarly on the LAD, sometimes you can get caught out because when you look at these scans, the diagonal's really, really far away and then you're thinking, well, if I'm going to divide it up based on that, it can be a bit confusing. Do I call a tiny weedy branch D1? So you'll develop the language. So principal diagonal is quite helpful if you're not trying to say it's D1 and you're not sure if it is D1. And similarly, you can divide it up arbitrarily, but that's the SCCT convention. Okay, so left main stem. Now, although everybody wants to get onto the curve reformats and straighten out the vessels and look at them in 3D, there's certain tricks that are extremely helpful when you're looking at the basic images. And you can do this on any kind of workstation, so it's well worth learning. So when you start on the coronal view is a really good view to look at the origin of the left main stem. And sometimes when you do curve reformats, especially when you're dealing with a very osteal stenosis, it can be very difficult to appreciate it when you're looking at curved reformats. So I'd encourage you to always look at the ostium of the left main stem on the coronal view. In the same way that one of the best ways to look at the ostium of the right coronary artery is actually on the sagittal view, so the LVOT view. So if you line up on the aortic valve on this view, you'll get that sagittal view. Just scroll up and down, you'll actually see the origin of the right coronary artery. And it's really important that you kind of develop a system, especially when you're first starting cardiac CT, because it can be quite overwhelming. And those of you from a radiology background know about this concept of satisfaction of search. You'll see a stenosis, you'll feel really proud of yourself because you've seen a stenosis, and then you'll miss like all the other problems in the heart. And that's the quickest way to destroy your service, okay? Because what you'll find is nobody comes up to you and says, oh, well done, you told me about this, this, and this. What they will do is say, oh, you said this, and it was this, okay? So you just have to mentally prepare yourself for all of these. Obviously, as a cardiologist, you won't have that problem because you'll keep it a bit quiet. Just like, oh, yeah, that's a good thing I did the cath. Okay. All right, so looking at the left main stem. Left main stem can bifurcate and it varies. Sometimes you don't even get a left main stem. You can get separate origins of the LAD and the circumflex. But you should always use the volume rendered images from the point of view of giving yourself the 3D anatomy. So where the volume rendered is very helpful, it's not for identifying stenoses, but it's to kind of give yourself the 3D orientation. Where it's extremely helpful is in coronary anomalies, because you'll often understand the courses much, much better when you look at the volume rendered. The difficulty that you've got is if the coronary vessels run in myocardium, then the volume rendering won't work very well. But this is great because all your surgical colleagues love these sorts of images. They're like, wow, this is amazing. Obviously, the kind of wow factor of CT has been, it's a few years now that we've had volume rendering. But, you still see people saying, oh, that's amazing. And you're like, yeah, whatever. Okay. Okay, so LAD running in the interventricular groove, and you can see the diagonal branches obviously going over to the lateral wall. The septal branches will be going towards the septum. Remember, the LAD anatomy can vary. You can get double LADs. You can get kind of LAD that then gives off a big diagonal branch. So you've just got to follow the convention when you're naming it and use the descriptive terms. I'd encourage you to take pictures to send them on your reports because often, picture states 1,000 words or whatever it is. So you can kind of get your point across much, much quicker just by showing people what you mean rather than trying to describe it in like 5 million words. Okay, so here you can see the LAD anatomy kind of running in the interventricular groove. Just here, you can see it here. It's giving off a big septal branch in this case. Okay, some of the LAD variations. So here, the LAD will always go towards the LV apex, but sometimes you'll see it petering out, and sometimes you'll get a big diagonal that kind of goes towards the apex instead. Okay, circumflex, should actually run in the AV groove, so you know automatically looking at the volume rendered image here, this cannot be the circumflex, okay? This is a branch of the circumflex, so this is an obtuse marginal, because the circumflex should be sitting plumly in the interventricular groove here. So that's why it's a useful rule to remember. Okay, circumflex variations, obviously you can get big obtuse marginals, circumflex can often be quite weedy. Okay, right coronary artery, there's the C that we talked about, proximal, mid, distal. Again, you can see the RV branches, you can see the conus branch. Again, if you look at the double oblique here, you can see that in this case there's a small vessel coming back, running towards the interventricular groove. This is the SA nodal branch. Okay, so what? And here's the conus branch. So where it can be helpful to say that the conus has got a separate origin is if, for example, you're dealing with a stenosis in the right coronary artery, and obviously your colleague at cath thinks, no, that must be the right coronary that's occluded, and they're shooting into the conus. And obviously, for those of you who do angiography, you know, kind of injecting into the conus is not a great thing to do because it can precipitate VT. Okay, right coronary anatomy again. Although the PDA traditionally arises from the crux, which is this bit here by the posterior AV groove, it can arise early, and it can actually arise extremely early. And similarly, you can often get larger branches coming off the PLA. So this is an example of codominance, where you see this vessel coming here. This is probably the right, this is the left, but this is a PLA, so the posterior lateral artery. So you can see the circumflex and the right are both kind of relatively the same sort of size, and that's codominant. The only reason to kind of mention it is when you're describing in a report, especially if you're describing stenoses and your colleagues are trying to work out, do I really want to take this person to cath? You know, they haven't really got any symptoms. I'm just looking really for prognostic disease. So you're just trying to help them make that distinction. And this basically is the SCCT coronary segmentation as we've gone through already. So right, we've said proximal, mid, distal, PDA obviously using kind of these are the, if you're doing studies, often you have to limit yourself to these segments so that they can marry it up with angiography. Most people don't use the numbered anatomy, okay? It becomes extremely confusing. So it's much easier to say proximal, mid, distal, osteo, or whatever. Okay, so here, does everybody know what vessel this is? So it's the anterior running on the left, so it's the LAD. So that is going to be a branch, so that's going to be probably obtuse marginal, I would guess, because the AV groove is back there. So this is still nevertheless a branch, isn't it? And here you're just picking out the LAD and you'll see kind of how this works. But basically, volume rendered image, very nice for presentations and everything else, but not really of diagnostic value. These are the curved reformats. And what the software's done is basically picked out the vessel and trying to give you two orthogonal views. So what you'll see, and as Taryn will show you, is you get two orthogonal views. Okay, so these are at 90 degrees to one another, and then this is the true axial of the image. And you see this little blue marker here. This blue marker corresponds to this blue box here. Okay, and then you've got 1 millimeter above and 1 millimeter below. So you can try to use that to judge coronary artery stenoses and look at the vessel wall in a bit more detail. But you'll kind of do that. So here, it's just emphasizing the fact that you can kind of resolve the vessel. It's actually very difficult to resolve the layers of the wall, but you can do it to a limited extent on CT, but obviously not to the same extent as something like IVUS, which is intravascular ultrasound, which has got the highest resolution. So again, looking at the coronary veins, I always draw a blank because I can never remember my coronary venous anatomy, much to my not much to Taryn's disgust. Taryn's thinking, oh my God, what a loser. But anyway, seriously, it's quite difficult. So you've got the coronary sinus. Obviously, you've got the great coronary vein. Those are the easy ones. And then I can never remember, is it the middle or is it the right or is it the lateral? Okay. But if you're going to do venous anatomy, especially if they're talking about putting in biventricular ICDs and they want to know, is the venous anatomy normal or is it varied? You can use CT, but again, you have to modify the way you give contrast because you don't normally get a pacification of that, which is why I don't know it, obviously. Okay, so coronary veins, again, you can kind of show your colleagues and you can look, see, you can understand why they try to get the middle vein or the lateral vein. I can't remember clearly which one it is for the coronary biventricular pacemakers. I wouldn't be able to name any of these, to be honest, apart from the coronary sinus. Okay, so this is just an example of somebody with a biventricular pacemaker. You know it's a pacemaker, not an ICD, because they're thin lines. You've got one that goes up into the right atrium. This is obviously in the right ventricle. And then this is the one that lies in the coronary sinus. So that should be slap bang against the lateral wall. Okay. All right. Do you have any questions?